All right, folks, we are back. This actually is going to be our last presentation for the day. And if you have any questions, like always, shoot them to me in the chat box, or you know how to get a hold of me. I'm going to turn the microphone over to Dr. Cox. He's going to talk about acute coronary syndromes. Thank you, sir. You're all set.
No problem. All right, folks, my name is Adam Cox. I'm one of the emergency medicine residents over at Freeman. I was going to talk a little bit about what I'm sure is your favorite topic, acute coronary syndrome, and maybe a little bit about heart failure as well, since often they're somewhat connected. I know a lot of this is review, and so we'll try not to spend a lot of time on things that are too obvious and maybe look at some EKGs. And I will say that this is one thing that probably bears refreshing often for all of us. Obviously, it's a big complaint that you guys go out to and that we see all the time. And so we'll just dive back in. So obviously, people don't call into 911 or even come to the emergency compartment complaining of acute coronary syndrome. They say, my chest hurts. So just kind of thinking broadly about things that can cause chest pain. This is by no means an exhaustive list, nor is it a very good list as I look at it now. But there are plenty of things, whether it be trauma or just regular musculoskeletal complaints, even GI complaints, things wrong with the lungs that can cause chest pain, not just cardiac issues. And there can even be other cardiac issues that don't really fall under the category of acute coronary syndrome that we would think about as well. So part of the challenge with seeing patients complaining of chest pain is narrowing down exactly what this is. Obviously, we don't want to miss a STEMI, but we also don't want to miss lots of other things. And sometimes that can be difficult to discern when you're talking and examining patients. So things to think about: are their symptoms typical or atypical? Are they having typical symptoms that we would be worried about acute coronary syndrome? Chest pain, that seems to be worse with exertion. Shortness of breath on exertion. And we'll talk about some other things as well, but those would be the big things. A little twinge of chest pain that just happens while they're laying down. While it could be acute coronary syndrome, certainly isn't as convincing or as worrisome as someone who was out mowing their yard and suddenly they had this intense chest pressure and got real diaphoretic. Things that we are trained to think about and ask about. Risk factors are another thing to start thinking about when you're evaluating somebody with chest pain and you're worried about acute coronary syndrome. Do they have a history of hypertension? Do they have a history of prior MI? Are they smokers? Do they drink a lot? Do they have diabetes? Things like that, which we well know kind of help us begin to risk stratify these chest pain patients and try to figure out what camp they belong to as far as the etiology of their chest pain. So I think one of the most important quotes, and this was directed toward the emergency department, but really I think applies to all of us, is that the history is the most sensitive test for the detection of acute coronary syndrome, which far surpasses both an EKG or cardiac markers such as troponins. So the pitfall is that we see people with chest pain and we don't take a good enough history and we don't have a high enough index of suspicion to admit people for chest pain, and then they go home and then they have a heart attack. When a good history sometimes can really lead you down the path where you need to go, even when you have a patient with a normal exam and now they're chest pain free. What is it in their history that is concerning or not concerning? It makes you think, hey, this person probably needs to come in, they need to be admitted, they need further evaluation of these symptoms because they've got these historical factors that are worrisome. So that would be my first point. What history is behind this chest pain, and is it concerning or not? Second thing to probably think about is there are many other things aside from chest pain or pressure that can throw someone into this category of acute coronary syndrome. So we call these anginal equivalents. Maybe they are just short of breath. That's why we get EKGs on people that are just short of breath. Just same we do as if they have chest pain. Maybe they just have jaw pain. Maybe their right shoulder hurts. There are some studies that would suggest that right shoulder or right arm pain is even more sensitive for acute coronary syndrome than pain radiating into someone's left shoulder or arm. All those things can kind of be clues as to, hey, this person may have something going on with their heart, and we need to investigate this further. Different groups of the population present differently with these anginal equivalents. Elderly people are notoriously don't just necessarily come in complaining of chest pain. They may have some of these other symptoms, which really forces you to have a higher index of suspicion in that portion of the population. Women, the same way. Very typically would potentially have more right arm symptoms, or even right chest pain, as opposed to substernal or left chest pain. Diabetics frequently will present just short of breath. That is their anginal equivalent, because of the way that disease process affects their nerves and the way their body responds to pain. Third point here is that a physical exam often tells you nothing. I'm sure all of you understand as well as I do that someone can be having a humongous STEMI and their physical exam is rather unremarkable. They may look uncomfortable, but their heart rate might be normal, their blood pressure might be okay, and yet they are having a pretty significant disease process going on. By the same token, you may have someone who's complaining of chest pain, and you push on their chest, and oh yeah, that's that pain, that's it hurts. And it's very easy to write that off as a musculoskeletal pain, and that is a huge pitfall. Studies have shown that that does not correlate at all, and people have had significant coronary issues that had reproducible chest pain. So that all goes back to that previous top point, in that history really is going to be your best bet at weeding through a person's complaint and trying to get to the bottom of what's going on with them. So when we talk about acute coronary syndrome, really this is just kind of an overview of chest pain and the disease process. It's really the last three that would kind of encompass this entity we call acute coronary syndrome. We're just going to go through these kind of one by one, and I'm sure a lot of this is review, but it helps to kind of think about how the process works and how that's reflected in someone's labs or their EKG. So stable angina is what we typically think of as chest pain with exertion. And then they stop and they rest a little bit and it gets better. So that's the result of a thrombus that's formed in a coronary artery. And there is a little bit of narrowing of that vessel because of it. Enough blood is getting through when the person is at rest, but when they are exercising, their heart has more demand, and so less blood gets through at that time because of that narrowing. And so that's when they start to have chest pain. When their heart rate normalizes and the demand decreases, then their pain goes away. They're likely going to have a very normal EKG. Unstable angina is where we start getting into this entity known as acute coronary syndrome, and this is something that could rapidly progress to an NSTEMI or even STEMI, because they're all really kind of on a continuum when you think about it. This is when you have that same thrombus that we already talked about, but plaque, but then you have a thrombus that has formed after the plaque ruptures. So now you've got a partially occluded vessel, and you've got a lot less space than you once did for blood to flow. And so now, even at rest, people begin to have symptoms of chest pain because the demand is there even when they aren't exerting themselves. And this is where you might begin to see some EKG changes, such as inverted T waves or even some ST depression. We're not really to the point of any kind of heart damage yet, but it's certainly headed that direction. An NSTEMI is sort of the next logical step in this, where you've got that thrombus, but it has occluded enough of the coronary artery that you begin to have some subendocardial damage. It's not full thickness damage to the heart muscle, but it's partial infarct. You may still see some of those same EKG changes that we already talked about, but you aren't to the point where you really see any kind of ST elevation yet. The thing that differentiates this, in addition, is that with this, as opposed to just regular unstable angina, the difference here is that you would likely see some sort of rise in their cardiac markers, such as a troponin, without any convincing ST elevation. That's going to let us progress to a STEMI, which we're all very familiar with, where you might get these hyperacute T waves or ST elevation on an EKG with a rise in the troponin, and that's where you've got a transmural infarct, kind of a full thickness to the heart muscle. All right, and this is the thing that obviously we know needs to go to the cath lab, and we'll talk more about this in just a little bit. So obviously we're going to get an EKG on all these patients, and you guys look at tons of EKGs, probably as many or more than I do. What, in the absence of ST elevation, which we know what to do with, what are some other things to think about in terms of an initial EKG that is not a STEMI, but that might not be normal, and what are things that we should be concerned about for some sort of cardiac process going on? So these high-risk features obviously would include ST elevation, but ST depression is also very concerning. We've already kind of discussed that. Any kind of pathologic Q waves, which we can look at here in just a minute. T wave changes, whether those are inverted or those big hyperacute waves, might suggest some sort of evolving process. Any kind of left bundle branch block, especially a new one, which we don't always have the luxury of knowing if it's new or not, but a left bundle branch block suggests that this person has either at some point in the past or is maybe even now having or has had some sort of issue with their heart. They've had some damage to the heart muscle that has resulted in this block. So they're probably, if nothing's going on immediately, they probably are still at higher risk, and we should have a little bit more speed in getting these people looked at. Any kind of left ventricular hypertrophy, which most often would look kind of like big dagger-like QRS complexes in the septal and anterior leads, V1 through V4. That's going to suggest also that this person's heart is probably not exactly in the best shape, and they're going to be at higher risk as well. Finally, any kind of abnormal conduction or ventricular paced rhythm, and certainly anything that looks strange when the person is having pain and then goes away on an EKG once they get more comfortable. Maybe you've given them some nitro or some fentanyl and they're feeling better, and then their EKG normalizes. That is very concerning as well. That person definitely needs to be evaluated and probably needs to stay in the hospital. So this is just kind of depiction of some of the things that were just on that last slide. And really what this slide though shows is more of kind of an evolution of a STEMI or STEMI in progress, and how that carries through over some days, even past having a STEMI. So you've got on the left a normal EKG, and then you might end up seeing with some sort of significant heart damage these hyperacute T waves in that second box, which progresses to full ST elevation within hours. Later you're going to see that Q wave, which is that first negative deflection of the QRS complex, which often become more pathologic and will remain far after the initial MI happens. You can have a little bit of ST elevation with the T wave inversion in some days, and that will usually normalize, and then you've got a regular T wave after that. Any kind of LV aneurysm can present as this persistent ST elevation, which looks like that last box on the right. That doesn't always happen, but that's also something that you could see. We're going to look at some EKGs and talk a little bit about different patterns of STEMI. I'm sure you guys have seen many of these before. Some of them I thought were rather tricky, and we'll talk about a few outliers as well. But this particular slide is just to sort of visually map out a 12 lead EKG and think about where somebody might be having an issue with their heart. And that's helpful to know for you guys, because obviously there's some medications that you might not want to give depending on the type of STEMI that someone's having. It's also helpful just as a heads up if you're bringing somebody in, so that we know where to look, so that the cardiologist knows where to look. All right. And so you can sort of map out these, and you can map out to some degree what the actual vessel is that's causing the problem. For instance, in the lateral leads, you would think of probably a left circumflex or maybe a diagonal. The inferior STEMI is, for most people, going to be the right coronary artery. We know that most people are dominant, right coronary dominant. That left circumflex can also be a player. There's a smaller segment of the population that can have that portion of the heart supplied by the left circumflex. So that's sometimes a player, but generally not. The large kind of anterior septal portion is generally supplied by the left anterior descending artery. So here is just an example. Obviously there's some ST elevation that jumps out quite obviously in leads 2 and 3 and AVF. If you look at those, you've got at least half a big box there in 2 AVF. And so you've got some reciprocal depression also if you look at 1 and AVL. All right. This would be indicative of a likely RCA occlusion. All right, potentially a right ventricular infarct. So just to the point I was making earlier, this would not be the patient that you would want to give nitroglycerin to. These people are often preload dependent. If you take that away, they can go downhill very quickly. They need all the pressure they can get. And so the best thing to do for these folks is give them some fentanyl, make them a little bit more comfortable, and get them to the hospital. All right. So in this EKG, you can see some fairly abnormal findings in those kind of septal and anterior leads. You've got elevation in V1, V2, some very hyperacute T waves, and some elevation in V3 and V4 as well. And remember, we're also looking for reciprocal depression, and so if you look over in the inferior leads, you can see that there. So as we talked about earlier, those septal and anterior leads are going to be associated with the left anterior descending artery. All right. These are at high risk for conduction abnormalities. You can get all manner of blocks and LV dysfunction. It's because that artery supplies such a wide territory. So this one is a little bit trickier. There's some obvious elevation in 2 and 3 and AVF, which would make us think inferior. Can see some depression in 1 and AVL, but if you begin to look kind of at those septal leads, especially V1 and even V2, you've got some elevation there. And so that is a little bit of a different story. V1 is the only lead that looks directly at the right ventricle. So this would be a right ventricular infarct with all of the elevation that you see, especially there in V1. It's not particularly common, but it's going to happen with that inferior MI, which we already saw in 2, 3, and AVF. And like the inferior STEMI, these are very preload sensitive. So you want to, again, this would not be a great patient to give any nitroglycerin to. You can do a different sort of EKG, and I have never done one of these, and I don't even know that anybody in the hospital is really trained to do these, but it is possible to switch your leads around, and you can do get those leads to look at the right ventricle. You just kind of switch them around the other side there as depicted, and then you can start to see some other elevation in V4R that's circled up there, and that's looking more at the directly at the right ventricle, and that's the most sensitive is V4R. So this is a different pattern. If you look closely, you can start to see some elevation in 1. It's pretty obvious. AVL is pretty obvious. And then I would say V5 has some elevation. You can see that J point there is at least a couple of small boxes elevated, and maybe even just a little bit in V6. And you've got some reciprocal depression, certainly in 3 and certainly in AVF. So this is going to be a lateral wall MI. Got those big hyperacute T waves in V4 and V5. All right. This is going to probably be an LAD or maybe even a circumflex occlusion, as we discussed earlier. This would also be at higher risk for some LV dysfunction. This one is a little bit more subtle in some aspects. You've got some elevation like we've seen before in 2 and 3 and AVF. And you've got a little bit of extension if you look closely into V6. Those T waves are a little acute as well. You've got some reciprocal depressions in V1, V2, and V3. This would be indicative of an infralateral STEMI, probably from a left circumflex that feeds into the inferior portion of the heart and also that lateral aspect. This one has a couple of positive arrow signs to help us out. Again, you've got 2, 3, and AVF, which certainly don't look normal and have some elevation there. You've got some depression in 1 and AVL. You've also got these depressions in V1 and V2, which don't necessarily correspond to the pattern that we would normally think about a reciprocal depression. So what's going on with those? Well, this is where we get into the difficulty with a regular 12 lead looking at the posterior aspect of the heart. Can have elevation that appears as depression when you're looking at it, a normal EKG, but it's a posterior STEMI. So this one is affecting the inferior aspect as well as the posterior aspect. If we were to flip that around and do some posterior leads, as indicated here, you would see the elevation in V8 and V9, which is looking more directly at the posterior aspect. The reciprocal depression then would be in V2 and V3. This is probably a branch off the RCA. This could be a circumflex. All right. This is a little bit of an ugly EKG, and it's not immediately evident what's going on here. There's some kind of diffuse issues. There's a lot of depression going on. You can see depression in 1, you can see some in 2. I would argue there might be a little bit in AVF, and maybe even a little bit laterally. The EKG is not the best. The culprit here, which we often neglect to look at because it's just kind of the one that gets ignored, is in AVR. So if you look closely at AVR, it's got some significant elevation there. That is highly specific for a left main occlusion or an LAD, one or both. Pretty proximal LAD, or it could be the entire left main. These folks are also high risk for multivessel coronary disease. You can get an infarct of the septum, and the diffuse kind of ischemia that we see with all those diffuse depressions causes all that reciprocal change there. That's just kind of a depiction of the heart, you know, in terms of where your depressions are going to manifest and what AVR actually looks at and how that corresponds to this particular STEMI. I think it is important for you guys, and I'm sure that you've heard of these and probably looked at them before, but they're always important to keep in mind. These two entities are basically STEMI equivalents. These end up going to the cath lab, much like an obvious STEMI. They're not quite that, but they reflect usually a pretty significant disease pattern, and they're good to be aware of. If you see any one of these, this is something that needs to come in quickly and that we need to get evaluated. So the first type we would talk about is this Welland syndrome. This is indicative of a critical left anterior occlusion. And you get these two different types. So type B is the most common. It's where you get these deeply inverted T waves across the kind of precordial leads that look just like that. Often these will happen when the patient is pain-free. They can even normalize when pain occurs, so it's a little bit of, I guess, a oxymoron of an EKG. You can also get this type A, which we would classify as kind of a biphasic T wave, where you've got that upsloping and then it drops into a more negative deflection. So two different types. These are high risk and need to go to the cath lab. The other one, which is probably less common, is this De Winter pattern. So again, this is something that you need to look at AVR for. So you've got some kind of upsloping elevation in AVR, and that's usually accompanied by these tall T waves and some depression in the precordial leads. This is also very specific for usually a critical left anterior occlusion. So the other, I guess, kind of more specialized issue is what to do with these left bundle branch blocks. We see a ton of people, they come in, they've got a left bundle. Any new left bundle we worry about a little bit more than somebody who's had one for a long time. But the left bundle itself looks like a STEMI anyway. And so how do you tell if someone's really having a STEMI with a left bundle? Well, this guy named Scarbosa came up with these different criteria to sort of stratify these folks and to say, well, this is probably abnormal enough that they need to be evaluated more than just say, hey, they've got a left bundle branch block. It's sort of ranked by points. So these three different things can give you different points. And anything of 3 or greater probably needs to be seen by cardiology. If you've got something that looks like that first entity, where you've got a QRS complex and then a T wave that go in the same direction, which is to say they are concordant and they're elevated, that is a very big deal. Normally you're going to have a QRS going in one direction and your T wave's going to go in the other. Normally you'd have the negative QRS and then your positive kind of big T wave that kind of looks like a STEMI, but it's just a left bundle. When you've got them going in the same direction, that's concerning with elevation there. That thing automatically gets 5 points, and so you're kind of done. The middle one, you've got some ST depression greater than a millimeter in V1 through 3, and you can see that depicted there. That's not particularly normal. Usually that slopes all the way up above the kind of J point, and then you've got your normal left bundle. So that is concerning as well, any kind of depression there. The one that's a little bit harder to differentiate is that third one, which only gives you 2 points. So that doesn't necessarily give you exactly what you need, but I still think it's concerning. If you've got a discordant, meaning going opposite direction QRS into your T wave, that's greater than one big box, so greater than 5 millimeters, that also gives you some points and probably should make you a little bit more concerned that, hey, maybe this left bundle isn't just a left bundle and they may have some underlying issue going on. So we've been through a bunch of STEMIs, and so what are we going to do with these people after that? Well, as you guys know, we activate the cath lab, and that is the gold standard. So there's sometimes some issues with making that happen. If we're here at Freeman, generally time is not that big of a deal. They get here, they go to the cath lab. If you're bringing them from someplace a little bit farther away, then sometimes that's a problem. So 90 minutes is usually the goal. If they come in the door, they need to have a balloon in 90 minutes. If you're getting transferred, it stretches out to 120 minutes. If you can't meet those, then TPA is still an option, and that's not something that you guys would necessarily give, but we have to think about that. So the reason that I put this here is because knowing the history of a patient that might end up needing TPA is particularly important, because there's plenty of contraindications to giving somebody a powerful blood thinning medication. Anybody that has had prior hemorrhage in their brain or brain cancer, if they've had a stroke in the last 3 months, if they're currently taking oral anticoagulants like Xarelto or Eliquis, any of those NOACs, and they've taken them recently, like within the last day, that would be a contraindication. If their INR is above 1.7 and they're on warfarin, that's also a contraindication. And there are some others that are good to know about. I'm not going to read through all of those. The other thing to kind of remember is that, even when I was in med school, which really wasn't very long ago, we still we're taught about MONA, morphine, oxygen, nitro, aspirin. Really, a lot of that has been, let me go back for a second. A lot of that has been, still not doing what I wanted to do, sorry guys, has been debunked. Morphine can cause significant problems, especially in these patients with MIs, and so a lot of times that is not indicated anymore. Oxygen, just giving oxygen to people can increase free radicals. There are other deleterious effects, and so even just placing people on supplemental oxygen if they don't need it isn't necessarily a good idea. Nitro is sort of hit or miss. We still give it, and it certainly can help. There are instances where we don't want to give it, and we've talked about that. And so even using that judiciously is probably a good idea. Aspirin really is the only thing that's still proven to be of a benefit. In fact, it's the only thing that has a mortality benefit in acute coronary syndrome. So full dose aspirin if they haven't had it. The rest of those is kind of proceed with caution. I generally think fentanyl is a lot better plan. It has a lot less effect on blood pressure if you need to get somebody comfortable. And so that's just my 2 cents on that. So what are our complications? There are plenty of complications, and the reason that these are up here is because maybe somebody has had an MI and they go home and then they have to come in a day, a week later, maybe even months later because they're having some issues. So one of those issues is that these people are at high risk for dysrhythmias. And they can take the form of Brady dysrhythmias. Sinus Brady would be the most common, but really any heart block they are at risk for. They can have tachydysrhythmias of basically any sort. AFib, they can get an accelerated idioventricular rhythm. Anything like that is an issue at any time. Heart failure is intimately connected to MI, and at least 20% of acute MIs will have some type of ischemic cardiomyopathy following their heart attack. So that's part of why we're going to talk a little bit about heart failure, just because they're so intimately connected. So you can have ventricular free wall rupture. This is usually an early complication, so 1 to 5 days post-infarction. These people are sick and will die quickly. The wall ruptures, they can have pericardial tamponade, then they have no pressure, and then they're dead. So they're going to be hypotensive, they're going to be in a lot of pain, they need to get to the hospital, and they need to have surgery. They can have a rupture of the septum if they've had an MI that affects that part of the heart. So they get a left to right shunt. If there's a rupture there, they're going to be short of breath, they're going to have a murmur, and that is also something that needs surgical repair. Dressler syndrome is usually weeks after a heart attack, and that's just a fancy way of saying it's basically a pericarditis that they get after having an MI. These folks hurt, but generally this is pretty benign, and they get treated with NSAIDs and they go home. so they might need to stay for a bit. But if you're thinking time frame, this person, no, they had a heart attack 3 weeks ago, maybe this is a Dressler syndrome, and you would see the typical EKG changes with some diffuse ST elevation across many leads that would lead you to maybe think that. And then finally, something that we see often, especially in our patient population, is a restenosis where they get a stent and either they're just in that poor health or they're non-compliant with their medications and they get restenosis of their stent, need to go back to the cath lab and to get that fixed. This is a very busy slide that it just kind of starts to lay out some of the pathophysiology of heart failure that we're going to talk about briefly. And I don't expect you to know this. I don't even know all this stuff, and I don't want to. But understanding that basically there are a lot of physiologic pathways that get activated once there's been some sort of myocardial injury. And then that leads to remodeling of the heart, which basically worsens the function of generally the left ventricle that then proceeds to heart failure. It's that remodeling that people take medications for to try and slow down or prevent, such as a beta blocker or an ACE inhibitor, things like that. So that is the goal of the medical management following a heart attack, is to kind of lessen these symptoms, which likely many of these folks are going to have. And this is a large kind of flow chart that kind of goes beyond a lot of what you would all do in the field, but really step 1 and step 2 are kind of where you guys come in, which is to, first of all, determine how stable the patient is, because as you well know, there are many kind of manifestations of heart failure. Some of these folks are just a little bit swollen, and that goes from that end of the spectrum to cardiogenic shock on the far end, or I should say also flash pulmonary edema potentially. So are they stable or unstable, and how are we going to treat that? Are they unstable? Are they having heart failure because they're having an active MI, because the two can come on together, and so do we need to do something about their MI? And then starting some sort of treatment. Do they need some nitro? Is that going to help temporize them because they're in fluid heart failure and they've got a bunch of fluid in their lungs? Do they potentially need a pressor because they're hypotensive because their pump is failing? And are we going to maybe give them some dobutamine or some norepinephrine, things like that? Do they need to go to the cath lab because they are in heart failure but they're having a heart attack and they need their heart revascularized so that their heart's going to work better? That's kind of where you guys come in the initial evaluation of these patients. All right. Supplemental oxygen is important for these people. Any hypoxemia is detrimental. All right. BiPAP is important, as you guys well know. It's going to help the heart function better and get some of that fluid off of the lungs. All right. So those are kind of the mainstays of treatment. From your standpoint, in addition to ours, and a lot of times we'll give diuretics as well once we get some of that fluid mobilized. This is just a depiction of this kind of nasty cycle of cardiogenic shock, and it's sort of a cycle that is like a snake that keeps on eating its tail, I guess, where you've got decreased contractility of the heart. That's going to worsen your cardiac output, which is going to worsen your blood pressure, which is also going to force fluid back up into the lungs and make you hypoxic. That's going to worsen any kind of heart damage they may be having. The decreased blood pressure is going to lead to decreased perfusion of their heart, which is going to worsen their heart damage, which is going to further decrease their contractility. And so the cycle continues. And so that's the real danger in this entity. If we can't help out their contractility, and if we can't revascularize a stenosed vessel, then this is going to spiral downward. So the mortality rate in cardiogenic shock is high, up to 50%, and a decent amount of folks with MI, acute MI, will have this, 4 to 8%. So it's not a small amount. and that's why we take these so seriously. This is just a very busy slide as well, with some arrows to think about different agents that are occasionally useful in cardiogenic shock. All right, dobutamine is important. It is inotropic, so it's going to increase contractility. It does not always do a lot for blood pressure. So if someone is significantly hypotensive, we probably need to think about a different agent. So norepinephrine is generally the go-to in that instance. All right, dopamine, I know used to be kind of the go-to. I can't remember the last time I've used dopamine, and so there have been other agents that have replaced that recently. So obviously we need to get patients stable if they're hypotensive, and so this is what we would kind of begin to think about. So we have kind of taken care of their STEMI. We've potentially taken care of some complications. Maybe they've been in some sort of cardiogenic shock. We've looked at that. How are we going to manage these people once they get to the hospital? Obviously, they're going to have PCI. We're going to give them aspirin, maybe nitro. They need to be on some heparin. All right. So some folks, if they're stable, don't have to have all these things that we've talked about. Maybe they are stable enough that they can have testing on an outpatient basis. Really depends on their history, depends on their risk factors. And some people we send out, some people we keep if we think they're poor candidates or they don't have good follow-up. All right. Just a few more slides, and this is just to kind of look at different types of cardiomyopathy. A couple of these we see often. Hypertrophic cardiomyopathy is more of a genetic issue. These are your young kids who inherited this, and then they have some issue while they're playing sports and they drop dead. That's why we screen kids for things like this. It's really, though, the dilated cardiomyopathy, which is going to come with a reduced ejection fraction, and then a restrictive, which is a little bit harder to understand. That's going to be more diastolic dysfunction. These are the things we see typically in our patient population. It's the impaired contractility, generally due to some sort of ischemic problem, whether they've had a heart attack or a bunch of heart attacks. Their heart muscle is weak, it doesn't pump well, and it's kind of ballooned out because it's weak. They have that low ejection fraction, and we worry about all kinds of stuff with that. These people are high risk for cardiogenic shock and all sorts of things. They have low cardiac output, and they're going to come in, they're going to have shortness of breath with exertion, they're going to be fatigued, they're going to be puffy. We know what this looks like, and we've already kind of talked about some of the issues with that. Diastolic dysfunction is a little bit of a different story. These people have a preserved ejection fraction, but they are very much, and sometimes harder to manage than the people that you can just stick on the BiPAP and give a little bit of Lasix to. These people kind of teeter on this heart failure and are hard to get a hold of. We see a lot of it, and a lot of it goes unrecognized in our patient population. They hypertension, which is rampant, of course, is a big risk factor for this. Their heart muscle gets stiff and doesn't really work well. So they have restricted ventricular filling. They have decreased diastolic volume, generally at least the left ventricle, if not both ventricles. All right, they have decreased cardiac output because of this, even though their EF is stable. They're going to get right heart failure. All right, they're going to fill up with fluid in their lungs, and a lot of these folks will get AFib as well due to kind of the backup then into the atrium. And this is our last slide, just to again think about what we're going to do with people in coming in with these heart failure exacerbations. This is broken down into 3 different types, and I kind of like the way that this looks. You've got what we talked about already, the kind of stable, mild exacerbation. They don't need a whole lot of stuff. Maybe they need some extra Lasix, and a lot of these folks can even go home, or maybe stay for a day to get diuresed and go home. Then you've got the folks that are in this acute pulmonary edema. This would be more of a flash pulmonary edema situation, where they're hypertensive and they have filled up with fluid, and so your BiPAP is going to be important here, nitro, Lasix, things like that. And then you've got the other end of the spectrum as well, which is kind of the hypotensive side, which is that cardiogenic shock that we've already talked about. These are the folks that are going to need pressors, quite the opposite of the last one we talked about, and they may need intubation. This depends on how stable they are. We already talked about the dobutamine, we talked about norepinephrine. So just kind of a way to stratify these in your mind. All right. These are my references. If you guys have any questions, we can do that, I suppose.
There's a lot of chatter, but I don't know that there was any questions. I was just looking at it.
Well, hopefully it was good chatter.
Oh, it was good. It's good stuff. Good stuff. Good stuff, Dr. Cox. Appreciate it very much.
It's not a problem. Hope you guys learned something.
Yep. Are there any questions for Dr. Cox?
We still have a delay here, but I haven't had any come across.
Okay. Just put that on mute so we can. Not yet. All right, folks, just stand by for a couple of minutes. I'm going to go ahead and get Dr. Cox on his way if you don't have any questions for him. But Dustin, Scotty, or myself may have a couple of messages for you here before we sign out for the day. So stand by for a couple of minutes. Be right back. Now it's on.
You gotta start over.
Oh, great. I got to start over. I didn't realize the mic was muted. How many paramedics does it take to operate a microphone?
More than 3.
Obviously. Okay, so as we wrap up our last day of our last broadcast, I just wanted to say thank you to Mr. Prosser for all his hosting and help, and obviously he's carried the lion's share of this for quite some time. Our goal is 3 agencies to assist each other a little better in training, work together a little better, actually a lot better because, we're in this for the long haul together to make sure we have great patient outcomes. So thank you, Mr. Prosser. And then who else do we have?
Scotty.
Oh, yeah, Scotty. Can't forget Scotty. I'm just kidding. Mr. Powell, he has carried the lion's share of scheduling docs and things like that. I'm not sure what I've done. I've taken all the phone calls. I've carried the lion's share in emails for my guys out there. I haven't laminated anything today. So try to keep things lively in the chat. Hopefully I did a little bit of that. Hopefully you're not, nobody's too upset about my EMT and paramedic jokes, but that's okay. We got to have fun at work and do this together. Absolutely. So as far as I'm concerned, I know we have some questions about homework assignments, reading assignments, quizzes, when the videos are going to be posted, if they're going to be available for some time, what's the deadline to get stuff done, to get credit. And I want to hand this over to Mr. Prosser so he can answer those questions. If you come up with a question real quick, please type those in there, and we want to make sure everybody's question's answered, and mainly so we can go home and you don't bother us. I'm totally not kidding either. So here's Mr. Prosser.
It's a little skunky in here, sorry. All right, everybody. Boy, it is too. What was that? It's didn't ripen here, that's for sure. It's time to be done.
Oh, it is.
All right, if anybody's got any questions, put them in the chat box for the next few minutes because I don't want to make this take very long. You should be able to see on the screen the CE Renewal homepage. That is computer view. That would be tablet view. And that would be your phone view. I've got right there on the top, if you can't see that, zoom in a touch. The evaluation for the 2020 CE Renewal on the very top there. Green box, or a white box outlined in green. Right below there are the 2 videos actually from yesterday that we assigned that were recorded from Monday when the speakers couldn't be here live for us due to COVID restrictions and such. Then right below that are the 2 quizzes. I had a 3rd quiz for you, but honestly, I've misplaced it. So guess what? You don't have to do a quiz, but I certainly need that evaluation done. That evaluation's like every single person who spoke over the last 6 days. So have fun with that. But it's either that or another quiz. As far as questions, as for when we're going to have to do a little bit of editing and still some grading of a few things, these items will probably be open. Honestly, it's the end of the day on Thursday. Tomorrow's a Friday, and next week's Thanksgiving. I think what I'm going to do is leave all this online and accessible to you until November 30th. By the end of the day, November 30th, that would be like, 10 or so days, including the holiday in the middle. If you haven't got stuff done, I know a good portion of you do have a lot of it done. There's a few slackers out there that still need to catch up. I understand. That's why we did it this way, so people with busy schedules and what have you could do it kind of on their own time. So November 30th is that Monday. I want to have all this wrapped up by then, and by that end of that day on Monday the 30th, I'll start making some of the videos unlisted, so you wouldn't find them unless you actually went through Scotty, Dustin, or myself to get them. The web page will probably remain the same until then, and then basically after that it almost all but goes away. So we don't have this sitting out there forever for people to do when we don't even realize it. So we basically turn it off after we're done. If y'all have any questions, I'll wait for a moment or two for anything to pop in the chat box. Otherwise, this renewal certification class for 2020 is complete.
So
any of the recorded content that might have even been from over about a year ago in 2019, those are a little harder to make comments on, but you still can. If you can't do it, certainly do your best. That would be the most helpful way, so it's all in one place. Use the sign in, sign out tool on the web page so we can track that time frame as to when you were signed in doing something, because all those are in the web page anyway, so you're going to be on there. I realize, and I'm going to go ahead and make those changes. Those are some of the edits I'm going to be doing and working on over the next week or so, is changing those links so that they actually will open in YouTube and take you there, so you have all those controls. Hope that answers that. Anything else? All right. No other questions. You know how to reach us. So we're going to sign out and be done. This is the end of it. See y'all later. Be careful and have a happy and safe Thanksgiving next week.